Okay, on behalf of all of us, we welcome you to this panel discussion on local regional treatment in breast cancer. We'll try to cover as much ground as possible in the next 40 to 45 minutes. And may I quickly invite all the panelists right away to this stage, which include Dr. Bhushan Zade from Pune, Dr. Vikram Maya from Bangalore, Dr. Monica Malik from Hyderabad, Dr. Shyam Sundar from Bengaluru, Dr. Tabassum from Mumbai.
Dr. Anupama Mane from Pune, Dr. Garvit Chitkara, Mumbai, Dr. Joy Ghosh, Pune, Dr. Lakshmi Nair from Cochin, and Dr. Rosina Ahmed from Kolkata. So we have tried to divide the session and clubbing similar papers together and then discussing them all together. We would not be able to cover all the papers, but we have tried to cover as much as possible, and it's only natural that we start from the paper which has been published or which is going to be published, which has been presented from our own institution or from our own country. So this is effect of peritumoral infiltration of local anesthetic prior to surgery on survival in early breast cancer. Study from TMH, over 1,500 patients with 72 months of follow-up and overall survival difference of over 3%, DFS difference of 5%. Full publication is still awaited, but it is a low-cost, simple technique and seems harmless. So my first question to my surgical colleagues on the panel is, would you or have you incorporated this in practice?
So no, we haven't yet incorporated this because we are still waiting for the full publication. I would like to read all the further details about it before.
Dr. Garvit, you must have been part of this study, I'm sure.
Yes, I was, and we were doing it at TMH, and now I'm doing it at Nanavati. But I do have to tell my patient, and because of the kind of publication that the kind of publicity that this paper has got, patients come asking for it also a lot of times.
Dr. Rosina?
No, haven't yet incorporated it, but I'm very interested to see the full text. I mean, there's a lot of information, as somebody who was not part of the study, a lot of information I would like to see before we decide about whether to implement it or not.
Dr. Ghosh and then Dr. Nair.
Yes, sir, not incorporated yet. So like the others, I also wait for the full text. I was also part of the study when I was in Tata, so I've seen how it's been done. But yes, like everyone else, we're waiting for the full text to be published.
Dr. Nair?
Yes, we have also not practiced this, but it is very easily doable. That is the beauty of this study. Very easily incorporatable, very few side effects.
Can you be a bit louder, please?
Very few potential side effects.
Closer.
So it's very easy to incorporate it, and we might try it in the future.
So Dr. Garvit and Dr. Ghosh, you must have operated some patients who had this infiltrated, and did you find any problems with assessing the margin of resection, because a lot of local anesthetic has been injected? I believe up to 150 ml of local anesthetic agent was injected all around the tumor.
It's not really 150, it comes out to be around
up to 150.
So it comes out to, for an average weight woman, it comes out to be around 60 ml, 10 ml on each surface. And when you're doing it, in fact, margin positivity has not increased because I'm using local anesthetic. So to answer your question, no, I haven't had a problem with margin assessment.
Okay. And any one of you, would you think this would also work after NACT? Can we, because now more and more patients are going for NACT, and we are likely to get very few patients who would come for upfront surgery, and I believe all the patients in this trial were of upfront surgery. Am I right, Dr. Vani? Yes.
So the first comment is the paper has been accepted by JCO. That's the latest news. We're just waiting for the final formalities of some conflict of interest forms, etc., to go in. But otherwise, JCO has accepted the publication, so I think we can all now consider the prospect of using it in all early breast cancers. As far as the locally advanced breast cancer is concerned, we don't have evidence. But if you look at the intervention, it's a simple intervention. We are doing the same procedure in early as well as in late. You're not harming a patient in any manner, and I think adapting it eventually into the post-chemotherapy situation will also come in. Third, positive margins. That is not dependent upon infiltrating a local anesthetic or a saline around the tumor. What it is really it affects is probably the use of cautery may be a little irritating because there is local anesthetic around it, and try to have an edematous tissue or a fluid that's around and try using a cautery. It's difficult to cut. But you have a knife.
So what I meant was, how do you decide how much you are excising beyond the tumor?
Nothing
because
changes
traditionally
into-
we do 1 cm,
We
but with
continue to
local
do the same.
infiltration, the tissues would expand. So you still do 1 cm.
No, it doesn't really expand that much. We are going around the tumor, yes, but the tissue doesn't really expand because it starts infusing into the surrounding tissue. Yes,
Dr.
Neeta.
Neeta.
Just to make a comment, because it came up very recently, somebody called Dr. Tanuja and asked her how we were assessing margins in this study, because it probably affects someone who's using it for frozen section. So when you're trying to do frozen section and it's an edematous margin, I think the pathologist has probably struggled. We have never used frozen for routine margin assessment. Excision is purely clinical, and
Or is it okay to inject maybe 2 centimeters away from
So
the
I think the
tumor
point-
all around, and then you don't
So-
have any problem in deciding the margins? Is
So,
that okay?
I don't think that that's the point, because you're not going to excise within the local or beyond the local. You're literally hugging the tumor and infiltrating, and you excise within that. You feel the tumor, exactly as what Dr. Vani said. And I think the assessment is more a pathological concern, where because it's a little edematous at frozen, I think we got a call because somebody had tried it. The surgeon had obviously tried it. So the pathologist had a concern related to it. But just to answer that, even they were able to assess the margins and it came back negative.
Thank you.
Was
So
there
we
a-
move on to our next.
So just one question, if I have
Yeah,
the-
sure.
So before that, we know the same group had got out the Proleuton study. We all are aware of that very important study. So have the surgeons adopted that study in their practice so far? Because study after study after study, these cost-effective studies are coming out from Tata Memorial Hospital. Are they being adopted at the ground level? So surgeons, I'm afraid
I have recently started. I have recently started Proleuton, and I'm going to start local infiltration.
So it's
as
been
I
10
think-
years, I think it's been 10 years, correct me if I'm wrong, that the study was published in the JCO.
Yes.
Right?
So it was in
So 10 years
2011, to
announced
be
that.
exact, it's 12 years since that got published in JCO. And now we have the peritumoral infiltration that's come in
So
JCO again.
why is there hesitancy in adopting these cost-effective approaches?
It's not. I think the hesitancy is, I have assessed when we did the multi-center study for the same in the high-risk early breast cancers, the hesitation was only one. The wait period between infiltration and doing the surgery. There has to be a 4 days of wait, and I think that is where the private practice and the high-volume centers who have, no hardly any waiting list are failing to accrue in those patients.
I think it allows 1 to 4 days, right? So 24 and at least 24
It's
hour
not
wait.
1 to 4 days, it is 5 to 13 days. It's 5 to 13. So 4th day onwards you can operate. 4 days you have to wait. 5th day you can
Okay.
operate.
Just to-
So the 5 to 13.
Yeah, so
After
we'll
13
move on.
we'll give a
We'll move on
boost.
to the next abstract now.
I think it's just about us accepting that it works and being able to convince our patients for that.
True.
Then they'll wait.
A well-conducted randomized controlled trial to convert into standard practice. That's where somewhere I read.
So
we should
6
wait
more
others.
years? 6 more years.
So that's for the loco-regional treatment in MBC, and this paper did show this is a trial, randomized trial by Seema Khan et al., who actually published the first study on this way back in early 2000, and did not show any benefit. However, there was better loco-regional control, and quality of life was same in both the groups in spite of not treating the loco-regional disease. There is another trial from Tata Memorial which also had similar results and no advantage was seen. However, if I remember correctly, at least in the later part of the trial, oligometastatic disease was excluded from the TMH study. So what have been the issues for these trials? May I ask all the panelists from maybe starting from the other side? Any issues with these trials of delivering loco-regional treatment in metastatic breast cancer?
No, but we are not offering loco-regional treatment in metastatic breast cancer until unless it is required for palliation or any other this thing. But we are not offering any loco-regional treatment in polymetastatic.
So otherwise you are
Polymetastatic-
satisfied with the conduct and the design of
Absolutely,
all studies?
sir. Yes.
Any
And
difference
now
of
there are
opinion?
4
Tabassum,
RCTs.
you have any difference of opinion?
No, No, I agree with, and this trial has actually resolved the issue of loco-regional radiotherapy. The issues regarding these trials were the conflicting results with the TMH trial and the Turkish trial, and the difference in the patient population, because TMH trial patients had not received anti-HER2 therapy to that extent, and hence the median survival was lower compared to the other trials. But this trial has now very clearly shown that it's not only about survival, but there isn't any improvement in the quality of life as well. So this is the most important thing, which will be very useful for counseling patients in clinics.
Dr. Rosina, you wanted to say
Just
something?
one thing to say, one of the reasons why there's confusion in a lot of the data is some of the trials are just going with standard treatment, and there are other focus studies which treat the oligomet site as well. I think let's exclude the people who have extensive mets. There's no question in those. But there are trial studies which actually treat the met as well as giving standard treatment, and I think that's where the conflict still is. There's no answers, because this trial didn't actually treat the metastatic site.
I think that's a very important point, because some group of trials have focused on treating or ablating the metastatic deposits,
Yes,
and
yes.
some have focused just on the primary site.
Yes.
And perhaps very few have focused on both, taking a holistic view.
That's right.
Yes, Dr. Goel.
Can we have some answer from Dr. Vani or Dr. Neeta? Because the Tata trial excluded patients with limited metastatic disease. Is their practice still offering local treatment to those patients, or after the trial have they given up on that?
So very quick, half a minute comment please from both of you.
Yeah, so M1 trial basically had looked at patients with 3 or more sites of metastasis. Oligometastasis was an exclusion, and oligometastasis had included anything up to about 3 to 5 sites that could be treated. So there were only 11 patients who really had oligometastasis. Neeta can probably give in more on the details, because she has looked at the details in depth.
Just to tell you, there were 83 patients who had less than 3 lesions. The rest of them were all disseminated disease, like Rosina mentioned. Of those 83, none of them had targeted treatment to the metastatic sites. They would have probably got palliative doses of radiotherapy to bone if required.
Correct.
That too if symptomatic.
Has our
So
treatment,
that is the point we were discussing.
Exactly. Has our treatment changed? For disseminated disease where we're not treating the metastatic site, we do not offer locoregional therapy. To oligometastatic, we're also currently treating the metastatic site.
So Turkish group has come up with a multi-center prospective registry also, and they have shown that even with large number of bone metastasis, they have better survival. And they have also shown in the subgroup analysis that if they do systemic therapy first vis-a-vis local therapy first, systemic therapy group has a better survival.
But these were only bone metastasis.
Very quick, Dr. Shabnam, please.
Just a question to the panel. You're clear on the frank metastasis patients not having any OS benefit. But if you have a patient wherein they have responded really very well systematically, would you like, and it is the disease is vanished, having good pathological response or radiological response, would you still not offer the treatment?
We are coming to these.
So we are coming to our points, but yes, I would like panelists to just raise hands if you would do loco-regional therapy for the group that she mentioned, or you would not. Yes, for raising the hands from the panelists, please.
They're doing
3,
really
4,
good. Yes.
Okay.
More individualized.
So it will be individualized in a MDT discussion that if
So I
the
think
patient is having
that's the
a
message
small
that we also want to give, that a good response of first-line systemic therapy and a good performance status and oligometastatic disease, I think we should offer them loco-regional treatment. If it is only local disease, which is the residual disease, or there is a discordant response and a local disease is progressing with controlled, very well controlled systemic disease, and for obviously palliative resection.
So do the panelists agree with this, right? So we move forward.
Any difference of opinion from the panelists or any additions?
I would just like to point out that the Seema Khan trial included the oligometastatic disease and still showed no difference in survival.
Yes, so that was a subgroup analysis that they did. Yes.
But I am still not aware about how aggressively they treated both, the primary as well as. I don't think they did. So that is the issue that we were discussing.
I think we are discussing a different group here in which the patients who are doing well on systemic are having a localized progression rather than upfront oligometastatic patients. These are patients who are doing really well on systemic therapy, and then locally they are progressing or they are having a locally bad disease. and then you want to treat that.
Excuse me. So we move on to the next abstract, the energy.
Can I ask one question? Yes, sir. Sir, after giving systemic therapy, if there are complete response even in metastatic sites, are they going to target even the metastatic sites or only the breast?
So again, there is no conclusive answer for the question you have asked, because, for example, you have a metastatic site which almost disappears. You have a lesion in the liver which has disappeared now.
True.
So what will you target and how will you target unless you have clipped it earlier or done something about it? So this question again needs to be answered. It's an important question, but we don't have the answer right now. So we move on to the next abstract, which is Energy BO2 trial, which has, I must say, broken the hearts of a few radiation oncologists as well. So it is a phase 2R, which was supposed to go into phase 3 design, oligometastatic breast cancer dedicated to breast, with oligometastatic, with good stratification, randomized arm 1, arm 2. One arm had standard systemic therapy and the second had ablation of all metastasis plus standard systemic therapy, and there was no difference at all in the phase 2 trial in the progression-free survival and even subsequently in the overall survival data, with a median follow-up of 35 months. So now with this data in front of our eyes, what is the situation regarding ablation of metastatic sites in breast cancer? Vikram, Tabassum, what are your immediate reactions to this very, very kind of concerning data that we are seeing?
Yeah, I would actually first look into the biology of the disease, whether, I mean, HER2 positivity and ER positivity and HER2, ER and the Ki67 index, and see the response to the systemic therapy. See, if you see the Sabre Comet trial, it had shown a good benefit in overall survival with respect to oligometastasis.
So what should be done now?
I would see how much of benefit it has with systemic therapy, and based on that, if it has become a very good response, then we would see if there is anything remaining to target those.
Monica, Tabassum?
No, I would actually differ a bit, and actually
Please
it's
speak
very,
closer
very,
to the mic so everybody can hear.
It's very, very disappointing that this study has not, I mean, shown any benefit with respect to survival, and we cannot compare this with the Sabre Comet because this is a purely, I mean, homogeneous population involving only breast cancers, and Sabre Comet had only, I mean, 15 to 20% of patients were of breast cancer. So yes, the BR002 has not included patients who are high risk. So definitely we don't know the answer for those kind of patients. But for ER positive tumors, once, I mean, we have not changed practice. I mean, we still do MDT for patients who should be treated with curative intent in oligometastatic disease. But once the paper is published, we will get to know the exact details, what were the ablative doses, what were the subgroups that really, was there any subgroup in the ER positive that benefited from SBRT? So we would get to know more details once the full publication is available.
So the other caveat besides waiting for the whole publication is that we have publication from other trials, for example, rectal trial going to the liver, where they ablated the liver lesion. There was no DFS or overall survival difference for 5 years, but then after 5 years, the curve started splitting. So perhaps maybe we should wait for a bit more time to see what's happening. Bhushan, you have a quick comment?
Probably in a select group of patients where systemic therapy has yielded a good benefit, and we have 1 or 2 resistant clones, probably they may progress later. So probably in that particular case, there is a case situation for ablative treatment there.
And also in that study, in the study 002 study, if you see what they have told is if the patient is not having progression or stable disease, they have taken the case for radiation. However, they have not told what is the response to the systemic therapy, whether they have responded very well or they have partially responded. Probably if you have that data, those patients who have responded very well to systemic therapy, probably they will do well with radiation to the metastatic
So to quote this landmark paper from Gundam, which actually dealt with prostate, but which told us that not only the metastatic site can itself throw metastasis and the primary site can throw metastasis. So both are probably culprits, but perhaps the same principles don't apply to each and every site, and each and every site could potentially be different.
Okay, so this study was done just to compare targeted axillary dissection and sentinel lymph node biopsy after chemotherapy, and it showed that there was no real difference between the two except that TAD removed one node less. And so my question is, and they had 93% N1 disease, but they also included N2 and N3, which is not yet recommended. They did not find any difference in any of the parameters studied. So what are the implications for our practice, and how many of the panelist surgeons would be comfortable doing SLNB or TAD in a node positive disease which has turned clinically N0 after chemo? Dr. Rosina.
I think this study actually gives us an opportunity which we didn't have, because there was this movement towards doing targeted axillary dissection.
Absolutely.
Which is done mostly using mag seed or radioiodine seeds, which are not available to us. Okay, very few patients. It's very cumbersome to do it in a with using the sort of markers that we use in the breast. So we did not have any opportunity to offer sentinel lymph node biopsy in this group if there was a difference between the two. But now this tells us that we may be safe to do it in spite of not having access to that technique. I think that's the first thing.
That's a very important point, because we have always been told that we have to clip the node and we have to
now
target the clip.
That is something in the near future we are not going to be able to do.
Yes.
So now let's say, now comes should we do it or not, but at least we have a technique that is equivalent.
Yes. Any other surgeon on the panel with any different view?
So with N2 and N3 disease, it still becomes a little difficult. You can consider N1 converting to N0 and then looking at doing an SLNB is fine. But with this particular study, they have given nodal radiation to both the arms. In spite of, so 80% nodal radiation is in the SLNB arm, and there's a significant difference there also because of the nodal radiation. So for this study particularly, I'm not very comfortable looking at TAD yet. Maybe once we have some more robust data where we can look at TAD as a standalone procedure, then I would be very comfortable doing.
So you are comfortable doing for N1 changing to N0 or?
N1 converting to N0, not for N2 or N3.
Anybody else practicing N1 converting to N0, doing SLNB and leaving it behind as of today?
We are doing it for select subgroups, HER2 positive receiving trastuzumab plus minus pertuzumab, or even triple negative, who have responded very well.
Okay. So then there is a study from MSKCC which has shown that you don't really need to clip it, or if not even target it, because clip is lost in 3% of patients. Ultimate retrieval of clip is only in 85% of cases, when dual mapping actually removes 3 sentinel node, which is the cutoff for a post NACT SLNB in 93% of patients. And the false negative rate of clipped node removal is 7% vis-a-vis 4% if we remove 3 sentinel lymph nodes. So Dr. Garvit, you have some proof at least here for not clipping it.
So again, Doctors Vani and Neeta, so TAD, sentinel lymph node, post NACT, why not sampling? What happened to sampling? Where does it stand in the whole picture? Why not a comparison with sampling?
So I'm going to say that the comparison has been done, published, and is there. I remember Dr. Sareen getting up in a conference and saying that this is probably a
post-NACT.
Post-NACT, this is probably the best place for sampling, because you want at least 3 nodes. You want good representation of the axilla, and sampling definitely gives you that. I think one of the biggest concerns with sampling and acceptance for sampling among clinicians has been understanding the morbidity. We hope to have some data on that soon enough. And I think Dr. Vani's already published post-chemo sampling. We're quite happy to offer that.
I believe TMH is also planning a study on post-NACT, SLNB or sampling.
There is only one caveat, and the caveat is it's the biology of the disease. We have very good systemic therapy now who can take care of most of it, and surgeons probably are not required anymore. But we don't know, when we don't do a complete surgery and we have disease recurring later, how does it behave? And I think that's where we need a long-term follow-up to get that data. Other than that, I think we are ready with the procedure. It has been proven and published.
Yes, but this study gives radiotherapy to the remainder of the axilla.
It doesn't. It doesn't.
She's talking about this study.
Sampling?
This study, not the sampling. This study gives radiotherapy to the remainder of the axilla.
Which is what Amaros also did, isn't it?
That is what Amaros also did. And
Which is
now,
what Acozog also did.
Yes. Absolutely.
So
but
if
Amaros is in the upfront situation. This is talking about all patients. If they have residual disease, they get a clearance, and if they don't, they get radiotherapy.
Well, I think that is an old subject now, because I'm sure Anusheel will agree and Vedant will also agree that these are topics that have been done and dusted. The surgery versus RT, probably the recurrence rates are more or less similar.
But not in the post-NACT situation. It's not
It
done.
will eventually come down to even that. But the problem will be the morbidity.
That's a fair point. Okay. That's a fair point, because you are on one hand you are not doing anything to axilla surgically, and then you are radiating the whole axilla. So that's a fair point.
Ultimately,
so we move on to the next abstract, from the PRADA, which is the primary radiotherapy and DIP perforator reconstruction of patients with breast cancer. So this is indeed a provocative study, and the fact that pre-operative radiation, which usually we don't hear much of these days, so pre-operative radiation, after giving chemo you give radiation and then you operate. So definitely this is thought-provoking, and any quick comments from both the surgical colleagues and the radiation oncology colleagues in the panel?
I mean, I would like to mention here that the kind of patients that these, they have not, they have amounted to only giving a primary radiotherapy, but they had a lock period of, I mean, after few weeks of hormone therapy, but the kind of patients which will be eligible in our clinic, I am not sure whether radiotherapy alone would give that much of a response rate compared to giving it concurrently with chemotherapy. So that will another that is another added option of improving the response rates. But if you have to talk about the reconstruction, yes, giving radiotherapy pre-operatively, either alone or with chemotherapy, will definitely improve reconstruction related outcomes.
So I think that was the main purpose of this study, as to allow and to test the safety of reconstructive procedure after having given radiation before. And to that, I think this small number of patients that they have shown us that the wound gaping is not too much, it's less than 5 to 10%.
So it takes a little while to heal, because most of the wound healing was complete by 12 weeks. At 8 weeks also, it was around 12% the wound had not.
So 12% is not less actually.
Yeah.
12% of patients having wound healing problems after 2 months of surgery, that's not less.
Yeah.
But then if you compare it with autologous reconstruction and then giving radiation, I think people have issues with that as well.
It is comparable.
So definitely when you compare it with post-operative radiotherapy, it definitely has a very promising
yes.
Okay. So this was a study on pathological complete response, and they did not show that there is any association between the pathological complete response and DFS or overall survival at the trial level, although there was moderate to strong association at individual patient level, and they have given several reasons. Like there is a different, this is assessing the response only in the primary tumor and not doing anything to assess the micrometastatic response, and possible solution could be adding ctDNA, which was mentioned in the talk as well. Then there are certain patients who do not achieve complete response because of the biology of the disease, but they are actually not disadvantaged because they are getting adjuvant therapy, which is very effective and should not reflect on the outcome as per PCR. And finally, it probably fails to capture the spectrum of response to therapy. So what is the final take on PCR? And I would like one of the medical oncologists from the audience to comment on this first.
Nitesh, you want to comment? We won't allow you to sleep.
So what is your take on PCR as a surrogate for DFS and OS post neoadjuvant?
I think I do believe in it quite strongly.
Closer, please.
I believe in it very strongly. I think the more we see, the more we are seeing that pathological CR is a good surrogate. Can we believe it in toto? I would not say so, but I do believe in it strongly.
So the other paper, and please stand there because we have more questions for you.
So you are still taking the stand that PCR is still the most important thing?
No, I did not say that. I said I believe in it. I did not say that I believe in it totally. It's not the most important thing.
All the surgeons on the panel are happy that question is not coming that side. So this residual cancer burden, again, this is not a yes or no, it is a continuum and a spectrum and has shown a better correlation. So my question again to you, which one would you prefer, PCR, maximum pathological response, or residual cancer burden?
To do what? What's your question? To
predict as a surrogate to DFS and OS.
I think RCV is a very good surrogate for poor prognosis. Much better than PCR is for good prognosis, clearly.
Okay. Can I add a point?
Yes.
Yes,
I,
sure.
I don't think so. I'm a medical oncologist, and I would like to put it forward that there is no robust data to say a clear correlation between pathological complete response and overall survival as of now. The data is still questionable, and we can have a debate or discussion on that, but it is not yet clear-cut that if you achieve a PCR, you may do better, but whether it will reflect into overall survival has not been shown as of now in any large randomized controlled trial, especially in the ERPR positive, HER2 negative. There is some data in TNBC, but not in the other subsets.
You accept that, and that's the right statement. The question is, what are you using that information for? If you are using that to talk to the patient that the outcome is poor or good, I think there is enough data to suggest that. But if you're going to change decision based on that in isolation, I think I'd be worried about that.
But so a non-PCR, you are saying that still is not mitigated by the subsequent adjuvant action that you take after having a less than a PCR.
You can see trial after trial that there is a benefit, for example, in CREATE-X, you can see that. But really what you're saying is that that is the higher risk group. That's why you're escalating care, isn't it? So now you have enough studies which are being designed to escalate and de-escalate based on pathological CR versus residual cancer burden.
Okay, thank you.
Thank you.
So intelligent vacuum assisted biopsy, again another promising technique, and they had published, they had presented in SABCS I think a couple of years ago. And this is an AI based learning algorithm using patient imaging, tumor and VAB variables to detect the residual cancer after neoadjuvant systemic therapy, and a very good false negative rate, nearly 0% to 5%, but a specificity of only up to 40%. And what are the implications of this in our practice? Surgeons, please, on the panel.
So for one, we don't have any AI-based vacuum-assisted biopsy system which is available in the market or in clinical practice yet. So I don't think any implications from the paper per se, but vacuum-assisted biopsy or vacuum-assisted excisions of tumor without margin, which we are all, I think, across the board, whether it is a radiation oncologist or medical oncologist or a surgical oncologist, we are all very worried about positive margins.
So we don't have the AI based thing, but now there is a study, although a very small study, which has shown 31 patients which has not used any AI.
So I'll come to that.
So even without AI, data is there.
Yeah. So no. There is 9. What they have used is an 8G needle, and they have taken 12 biopsies from 2 centimeter lesion, which would mean practically taking out about 5 centimeters of the breast for a 2 centimeter lesion, and then followed it up with 6 monthly mammograms, and 39% of their patients had rebiopsies or were advised rebiopsies. I think 23% were advised rebiopsies. I think it would have been much better if there was a small scar and a BCT done and the patient and the surgeon, I mean, this is something which is easily done, and an intensive
Is that the surgical oncologist bias?
Maybe.
No, I think somewhere it stops being a vacuum-assisted biopsy, and actually if you see the data in the trial, they have done an average of between 15 to 24 cores. I think somewhere it stops being a biopsy and it becomes a vacuum-assisted surgery actually.
So this is an important discussion, not a bias, Dr. Anusheel, because we we need to see what VAB does and what a BCS would do. Dr. Rosina.
Yeah, taking these two together, what it tells us is that it's feasible to do a biopsy and say whether there's PCR or not, and there are some AI tools that might help us to predict that. What it doesn't do is tell us how these patients will do in the long term. This is basically just the upfront information that you can say there is PCR or no PCR.
And
that's all it
so
does.
this study at least has a 2-year follow-up, which is obviously short. which
It's
is
a
obviously
very
short.
short follow-up.
Yes, very short, but it is a promising data. However, there are, as Dr.
In
Garvit
very,
mentioned,
very selected
there are
patients.
costs and logistics involved. They have to come for mammo every 6 months, and a third of them would be subjected to a repeat biopsy for an abnormal mammogram, which is quite a lot for our setup. And if I move ahead and what I mentioned, a clean BCS versus a VAB, this is what you see in a patient. So we have to understand, we are trying to give them comfort, we are trying to give them less symptoms, but we probably may end up giving more.
This is also a surgical bias, this picture.
So the other point that needs to be mentioned is that the specificity of VAB is just still around 40% or so, which means you are leaving around 50 to 60% of patients who actually had a PCR, you are not able to catch them. So I think that is also one facet of this entire situation.
Yes.
So please keep that in mind as well. So this is just a protocol which has been published last year, BMJ Open. It's hypofractionated versus conventional IMRT harvest study. It's a randomized non-inferior multicentric phase 3 trial. Now what is different about this trial? We have already seen conventional versus hypofractionated radiation in START trials and other trials and in the fast forward trial. The difference, Tabassum?
Yeah, I mean, I don't know when all these kinds of trials in internal mammary nodal irradiation will stop, because there's some on the other design, some techniques, some fractionation related, but we have already data from 4 to 5,000 patients that there is some benefit in breast cancer mortality, but there is no difference in the overall survival. So in fact, I came across, when you send these slides, I came across a precision trial in which they are seeing which patients IMN-RT can be avoided, considering that IMN-RT is a standard of care. I mean, considering 14, 15, I mean, we have been giving with this fractionation to internal mammary chain since last 2 years, and we haven't found any, I mean, difference.
So perhaps is to build the confidence in giving hypofractionated regimens for patients, even those who require IMRT, perhaps in a randomized setting, this trial will give us the answers for that.
It won't matter much, because we are already doing it for patients who have internal mammary node positivity, not in prophylactic setting.
Now, taking the radiation oncologist concern forward, we have one more trial which is testing supine versus prone breast radiation therapy for toxic effects on the skin. So, any quick comments, Monica, on this trial?
So, actually this, based on all the studies that were presented, there are benefits for either technique, and there are cons for either as well. Like the prone, we feel will reduce the side effects and the toxicity, but we've also heard that it can actually increase the cardiac dose in left-sided breast patients, and it's it increases the target volumes and also increases the difficulty of a nodal irradiation. But at the same time, for a large breasted patient, it can actually reduce the toxicity.
Bhushan, you have a comment?
Limited to patients with large breast size who need breast-only radiation.
Of course.
Especially for right-sided.
Except potential to reduce inframammary fold site reaction, I don't see any other benefit of prone versus supine, because your prone has got so many challenges.
So we have to be aware of the issues of prone position, including need for a larger bore for scanning, including the patient discomfort, and also ensuring that we don't end up giving a bit higher dose to the cardiac region. We know lung can decrease, but cardiac can increase.
cannot be practiced.
And we also need to compare against the best supine technique, which is the DIBH, which can further increase, reduce cardiac and lung doses. So these things have to be kept in mind.
We actually did a small study in Kidwai with the prone and supine, sir, exactly what ma'am told. We had more dose to the heart on the left side of the breast. And also it's technically very difficult for the bulky patients to lie prone.
Correct.
It's very difficult to make them
It's very difficult,
and there is the position every day.
And their positioning and their scanning itself is difficult.
Yes.
The first step itself is difficult.
It's very difficult. So that is the problem, practical problem we faced with the prone.
Yes. So as we'll realize over the next next half a day and then tomorrow, there is a big kind of a divide between where the systemic therapy has reached in terms of molecular-based assays, genetic markers, and where we stand as radiation oncologists in treating our patients. We have to admit that we are still working with the parameters of TNM and grade and other things, whereas our colleagues, better off colleagues, have marched much forward in terms of genetic-based therapies. And same, I think, for surgical oncology as well. They are with us for the time being. So these two studies are a small, tiny step forward in kind of giving us some message as to which are the patients we can escalate, de-escalate, leave, treat. So Lumina study, T1N0, it was presented today morning. Any difference between this study, so we know the events at 5 years, any difference between this study and the previous data from randomized trial that came, the CLGB and the PRIME2 trials, the BASUM? Do you see any new message coming up from the Lumina?
I mean, there isn't any new message because we knew that low-grade tumors, elderly patients, they have low risk of recurrence. So we already had that data from randomized trials. So I don't.
The only perhaps new thing which I see in Lumina is that they have lowered the age from 70 then 65. They've gone to 50, 55 now. So I think that is they are kind of trying to test the new lower age limit. So I think that is one new thing that is coming up in this study. And of course, in the same vein, we had the polar, the validation of profile of omission of local adjuvant radiotherapy, the polar gene signature, 16 gene mRNA signature, polar low, polar high tells us. So this gene panel actually is a prognostic for local recurrence as well as predictive for benefit from radiation. Some quick comments.
There was a similar publication 2 years ago, Arctic genetic signature also available from the Swedish randomized trial only. So I think this is just another kind of genetic signature, but if it is available, I mean, if
so would you be happy practicing polar for deciding radiation for your patients?
But it needs to have external validation in other...
They have done some bit of validation from previous patients. There was a test model, there was an experimental model.
Yeah, but it has to have external validation as well.
And the other thing, should we also be more keen to have Polar's effect on survival? Not only on radiotherapy effect, in terms of not only reducing local recurrences, but also improving survival.
That's the hardest endpoint, but we know if we, I mean, the ratio of local recurrence to survival, so that can still be extrapolated.
Actually, we need the robustness like an oncotype DX type of a formula. Once we get such a confidence in it, then I think we can start looking into it based on the cost and the Indian data available.
So I was in a panel in New Delhi. I was moderating a session, and there were 6 or 7 radiation oncologists. And I asked them to raise hands whether they are using internal memory radiation in all their patients, and all of them raised their hands. And that is why I'm wanting to ask this panel as well, especially in light of the data that is coming from this trial, which still I feel some people are keen to go ahead with internal memory radiation in most of their patients. So in view of this data that has come up, is the panel still convinced that internal memory radiation should be used as default in most or all patients?
No. No, we do not. No. This panel is not.
Contrasting panel. This panel is different.
Contrasting panel.
Any difference from the audience? Difference of opinion? So everyone agrees that internal memory should be used very sparingly. And yes. I, in my practice, use it only when I find internal memory nodes there, or even if they have resolved after chemo. These are the only situations where I use internal memory as of now. We have trials from URTC, we have trials from MA20. There are small randomized trials, but essentially I don't see any convincing data of survival benefit of incremental use of IMRT over and above supraclavicular medial axillary radiation. Can we have 2 more minutes?
Sir,
yes.
We have started using prophylactic internal node radiation if nodes removed was more than 10, say N2 or even N3 disease. Then we started using internal memory node radiation.
Based on what evidence?
There is no evidence. This is the one.
No, this is not an evidence because they don't have, they have not found any survival data. They have not found diseases, they have found nothing. Only in a subgroup analysis, that too was unplanned.
In
That
fact,
subgroup analysis was also unplanned subgroup analysis.
Yeah.
But in all RT trials, internal memory radiation was by default they use, and that is the data. And they've showed survival benefit with internal memory node radiation.
so the subgroups have always been conflicting. Earlier trials, they had said that it will be more beneficial in N1 compared to N2. So, and so all these subgroups that have been discussed are very heterogeneous. I mean, there is no consistently identified
So
subgroup.
quickly we conclude by this
I
Amaros
think
trial.
you have to look for the
By
pattern
the
of the
Amaros
local
trial.
disease.
Yeah, so we have very limited time.
Larger,
Buddhi.
small comment. Larger the tumor, it will affect the lymphatic pattern of the breast. So if it is a large tumor, I think there is an indication. And if the heavily infiltrated axilla, it will again block the lymphatic
We'll
axilla.
discuss, surely.
So alternate route is internal memory. I
We'll
think in those
discuss,
patients,
surely.
it can be
Amaros
done.
trial, again the findings are reinforced, no difference, overall survival disease, axillary radiation versus dissection, higher lymphadenoma, surgical arm. However, radiation oncologists, are you using this in your practice? Have you faced difficulties in planning? Is there a class solution? I, in my practice, tried 1 or 2 or 3 patients. I found the low dose region exceptionally high in many situations. And this is actually corroborated by what this abstract tells us now, that second primary cancers are slightly getting higher up, although it's not affecting overall survival. It's a very small number, but I think as radiation oncologists, whenever we adopt this strategy, please keep the low dose regions very, very tight.
True.
Also, we need to understand, although lymphedema is high, as Dr. Goyal had pointed out, there is no effect on the quality of life. And all these trials have been underpowered, so we have to be very careful. Thank you very much. Thanks, panelists, for a wonderful discussion.
Thank you
And
all.
the audience also.
Thank you.